exchangers of the gas. Welcome to the Gas Exchange Podcast, where we talk about anything respiratory critical care. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. My name is Keith Lamb, and I'm the host. I'd like to welcome my co-host, Thomas Perino.
Hello, hello.
And today's guest, Troy Whitacre. Troy is a highly respected respiratory therapist, a member of the board of directors for Inspire Respiratory Critical Care, and a regular contributor to our expert panel discussions. We are very fortunate to have Troy here with us today. Welcome, Troy, and can you tell us just a little bit about yourself?
Thank you, Keith. I am a clinical coordinator for a 36-bed medical intensive care unit at MU Healthcare, which is the University of Missouri, Columbia, Missouri. I've been here 35 years. I've been a respiratory therapist since 1982, and I've been at the bedside since then doing critical care 99% of my career. So
82. Did you say 1982? Okay.
Yes, I was
that's what I said.
I
said what I said. Yeah, you don't want to know. I won't even say what I was doing.
Were you born, Thomas?
I was, yeah.
Okay.
I was in,
you an embryo?
I was in kindergarten. Yeah.
Close. That's kind of like a toddler. So anyway, I should remind everybody that this podcast is part of our efforts at Inspire Respiratory Critical Care, which is at www.inspire-rt.com. And we provide the panel discussion I mentioned in our intro here with Troy is something that we do every other month now, and it's an expert panel discussion on a specific topic. We present pearls every week on LinkedIn. We have a service that we provide that's a virtual classroom lecture that we can do for any RT department, any class at a RT program, and other initiatives that we have going on. But this podcast is just a small part of that. So that's sort of the administrative stuff that we need to get out of the way. You told us a little bit about yourself, so you spend a whole lot of time at the bedside.
Did you say the part that this is just talking and not medical advice?
This is just talking. Don't listen to us.
Don't listen. Yeah, listen to us, but don't listen to us.
If you could do that at the same time, that's preferable. Can
it go in one ear and out the other? That'd be fantastic.
And maybe not stop in between. Yeah, good. So Troy, you have obviously a lot of experience in all the things that we talk about at Inspire. I'd like to hear a little bit about, I think that, something that we'd really like to hear about are your methods of getting some of the educational stuff that you provide to your staff. And I'm assuming that you have students that do clinical rotations at your facility also. Being a large academic center, could you tell us about how do you teach old dogs new tricks, and how do you teach the new dogs old tricks?
It's a good question, and then some of the more complicated things that we do, that are lower volume but higher intensity education. Those are the tricky things I think that everybody deals with that uses some of those tools that are available. We have an excellent educator here. Shar has done a phenomenal job getting different things together for education, but we focus mostly on trying to train a core group of therapists on different shifts to be able to, if not place some of these things, at least be able to know what to do with them if they are in place. And by tools and things, I'm talking about just, we use servo ventilators, and we have Hamilton G5 ventilators. So we have two different adult platforms. We use esophageal manometry on both the Servo U and the Hamilton G5. We use the tools that are available at times, like the open lung tool sometimes with the Servo U and the Servo I, which we also have, and the PV tool with the Hamilton. We also have Temple's EIT device, which we've had a couple of years. We have Nava that we use as well. So it takes some training, and we have people that are able to place them and help other therapists once they're placed. We have physicians that are pretty well versed with it too. Some aren't as interested as others, but once they're in place, we try to focus on, the placement's one thing, making sure they're in the right place, making sure you're getting accurate numbers. That's so important. You don't want to be making changes or looking at tools that are malpositioned or you haven't verified are in the right place. But once we're assured they're in the right place, then we try to train the therapists that don't actually place them. Okay, now what do you do with them? So you're here for your patient ventilator assessment. How do you inflate the balloon? How are you going to look at this? How are you going to you verify that it's in the right place when you're looking at it? So same with the Nava catheters and some of the other things. So we have a core group of people that are trained to do a lot of these things, and then we try to expand that out. If we're replacing one and there's another therapist available, hey, are you interested in watching us place this? It's also part of some of we have goals for their yearly evaluations. So a lot of these therapists will add these goals to these tools to their goals, and that's something they work on throughout the year.
I think you've quietly hinted at the most important part about utilizing these advanced tools with the equipment that you have, and that is having the proper support structure for it. So having a good educator, having someone like yourself training super users on different shifts. Like these are all things that without that, it tends to fall flat. And you highlighted the fact that some of physicians just aren't as interested in it. It's not that they don't allow you to do it. They're just not maybe
Correct.
the one suggesting to do it, right? So if they're not suggesting it, it's up to you to understand why you do these things, why this patient might be appropriate, and then having the courage. Sometimes it takes courage if you're not one to be, really outspoken. But the courage also involves the knowledge, right? Like no one's going to suggest doing something if they're not comfortable with what it means to do that, right? You're not going to have a bedside staff say, should we put an esophageal balloon catheter in, if they don't understand A, how to place it, B, what to do when it's in there. So having that support system and trying to maintain that, it is really challenging. I coming from a hospital that implemented transpulmonary pressure while I was there, and I was the sole person responsible for implementing it. This was years back after EP Vent 1. It's definitely a challenge because, you get certain people excited, but then you may go a few months without a case, right? Or you have cases, but the people that were involved with the cases the last time aren't working the shift this time. And so, the exposure is really part of the problem. And simulating this stuff is also challenging. It usually results in some sort of visual stuff, particularly with transpulmonary pressure. And EIT is a very visual tool. So, why don't you talk about your collection of screenshots? Because I can't remember when we started chatting, but it pretty much mostly involves screenshots from you over the years, which I love, by the way.
Yeah,
I
he's
don't
got
want
quite the collection, no
yeah.
doubt.
So, whenever someone's like, "Hey, what do you think?" and you just see like the message bubbles, I'm just like, "Oh, I hope a screenshot's coming." And then
Yeah.
boom, there's a screenshot from Troy. So, why don't you talk about your use of that? And I think we already know based on what you said the importance of taking these screenshots, but why don't you talk about that practice, because you clearly do it a lot.
I mean, there's a lot of things that you see that you come across, and one of the best ways to educate people or to talk about different things that come up are by taking screenshots. And we did this manipulation, and this is the result. We
Mhm.
did this intervention, and this is where we ended up. And that is for a wide variety of things. Just by adding a pause and volume control to a passive patient with ARDS and being able to see that you get the peak and the plateau breath to breath during COVID. We did that a lot during COVID. So as we walked by the room, all the physicians and the clinicians could just glance in the room and see exactly what was going on.
Yeah,
Patient was prone.
I
Yeah.
want to comment on that just briefly because when I started working in Toronto with Dr. Laurent Bouchard, um, I had exclusively been working in hospitals that used pressure control, essentially. A little bit of PRBC, sometimes,
Mm.
unfortunately. We've had this discussion many times, but but mostly pressure control. And so when I went to St. Mike's, I look around and I see that there's a few patients that are on passive ventilation. And I want to make sure this is an important distinction, because when someone becomes active, volume control can be a very uncomfortable mode, particularly if the flow is not set high enough. Like we use flows of 60 liters per minute, but I've seen other people use 30 or 40. And if someone wakes up on that, they're going to be immediately flow hungry. 60, you have a little bit of time usually, because when they're waking up from sedation, they may not have 60 liters per minute of flow, so they're not going to outstrip it. But anyways, I digress. When I saw these patients, I looked at the screen. I was like, "Oh, you guys use volume control?" And they're like, "Yeah, we use volume control for passive patients." And they said it just allows us to do more
Mhm.
advanced monitoring. And I'm looking at the screen, and I'm like, again, because I hadn't used volume assist control a lot, I had forgotten really the utility of this inspiratory pause setting of zero point 0.2 or 0.3 seconds, where most ventilators, the plateau pressure is just a bunch of stars. It's just asterisks if you don't actually have a pause. And then all of a sudden, I'm looking at the screen and I see a peak pressure. I see a plateau pressure. I see, of course, the PEEP setting. I see all of these pressures, and I'm thinking to
Mhm.
myself, oh my goodness, I know the resistive pressure. I know the plateau pressure.
And just one glance.
I
Yep.
know the driving pressure. I said, I haven't touched the ventilator and I know all of these things. And the cool thing about this 60 liters per minute is that's 1
The
liter per
math.
second, right? So the
The
math, you got
calculation.
yeah,
Yeah.
so for resistance, you've got
Yeah.
peak minus plateau divided by your flow in liters per second. Well, 60 liters per minute is 1. So you just divide PIP minus plateau by 1. So I'm just like, oh my gosh. I'm like, I have resistance, plateau, driving pressure. I can easily calculate compliance because I have plateau and PEEP and tidal volume. I'm like, this is crazy. I'm like, all of this information is just there. I don't, yeah. So when COVID happened, like honestly, that to me it was a game changer because it allowed in those early phases when the patients were, just initiated on mechanical ventilation, they're being proned, they're likely sedated and or paralyzed depending on the severity. I was able to monitor, like you could walk by and be like, that person needs suctioning because you'd see plateaus not changing, but PIP is higher. Like all of
Mhm.
these things that like you remember learning even as a student, right? You're like, oh, when PIP goes up and plateau stays the same, that's resistance. I'm like, but unless you're doing maneuvers, you don't know what the cause of the issues are when you walk by a room. So being able to visually see that was really, it was mind blowing. When you said COVID, I'm like, yeah, this was a perfect example where going into every room just to troubleshoot, it's a lot better if you know what a problem is sometimes before you go in, particularly when you have to gown up and mask. And, it was a challenging time for all of us. Right. So yeah, I just wanted to take a little side trip there with
When
the
you
volume control because the first time I saw it, I was just like, "Oh man, that's what a smart way to use the mode. Use it as a monitoring tool. It's not
Mhm.
that it's a superior mode, and I'm not saying it's superior mode, but as a monitoring tool, it gives you more monitoring information. But it's important that your patients are passive if you're using that mode. That's just my humble opinion.
When you mentioned the inspiratory flow rate of 60, it takes me back to when I trained in my first couple of years of being an RT, where everybody started to wear those Casio calculator watches because you had to do the math. I mean, the machine didn't tell you what the airway resistance was. You had to actually do these maneuvers manually and then do the math. We didn't even at first we didn't have monitors. We didn't have graphics.
Mhm.
For the first couple of years
And
that
yet
I
you were
was
still
working.
charting that stuff, right? Like I
Yeah.
feel like we went through a huge gap in
Yep.
critical care, at least respiratory therapy, where we almost stopped. I don't want to say caring, but like it was never a focus. Like I can tell you how many times I've heard handover either given to somebody else or to myself, and not one person is commenting on resistance and compliance. Like it
Right.
just wasn't something they talked about. They'll just say the patient's really sick. They might mention PF ratio, but this is even like before driving pressure. No one was talking about plateau pressure unless you were in a study.
Mhm.
You'd say, "Oh, our plateau is 28 because the limit's 30." But if the person wasn't in a study, we just weren't talking about this stuff. And I feel like COVID, people started paying a bit more attention, particularly to things at least like driving pressure. But really, I'm hoping for this resurgence of like understanding mechanics and the importance of at least tracking that and understanding how to manage this with your patient.
Gosh, I hope so. It'd be nice.
Yeah. So
Screenshots are just a, yeah,
back to
just a
what you were
great
Sorry.
saying,
way.
Troy. Sorry.
Great way. And even, with even maybe more simpler concepts, I've had multiple discussions with clinicians, including physicians, about, oh, what are you measuring a plateau pressure for and pressure support or pressure control? It's the same as you can see where you have your pressure
Mhm.
set. That's your plateau. No, it may
Yeah.
not be, right?
Yeah.
So
All
to
you got to do is look
show,
at your flow waveform, and it'll tell you whether or not
right,
you're going to have
right.
the
And
same.
Yep.
Yeah.
point that out, do a couple of maneuvers and show there could be a drastic difference, right? If the flow
Mhm.
doesn't return to zero or close to baseline on inspiration. And I tend, at least most of our patients we have are active, unless they're really sick. So I tend
Mhm.
not to let the flow return back to baseline because, if they wake up in pain, running a fever and they pick up their respiratory rate, I don't want them to start air trapping. So most of the time, and so that's a good good discussion point, screenshot here, different eye time, different scenario, and just show the difference. Hey, you still got room if you need to actually
Yeah.
turn the pressure up, even though your peak may be on the high side. You've got quite a gap, even in pressure control, to have a little bit of leeway to increase your volume for synchrony. So yeah, there's lots of reasons. Another good example would be when it looks like the patient's sucking a tennis ball through a garden hose in PRVC. Um,
Yeah.
and how
Yeah.
high?
I've seen
Yeah,
screenshots that you've gotten
Yeah,
with that
they look like they're in
scenario.
CPAP.
yeah,
Yeah.
Yeah, from the
yeah,
door
exactly.
until you get in to see the patient.
So and then you could put it out there and say this is something you need to pay attention to if you're going to use this mode. And how high does the pressure go in PRVC? Where's your pressure limit set at? What if the patient something happens? How high is it going to go to keep that volume? You need
Yeah,
to
right. If you have an acute change in your compliance,
Yeah.
like many ICU patients do.
Right.
When you brought up plateau pressure, it reminded me of a conversation I had not too long ago with a young RT that came up to me. It was I don't remember exactly what the beginning of the conversation was, but it resulted in this new younger RT telling me that they were told you can't measure a plateau pressure in anything except for volume control ventilation. And so I had to
Talk
we had
about conflating inspiratory pause setting with
yeah.
a maneuver, right?
Yeah. So I don't know. There's definitely a lapse in there's a gap in folks understanding. Can you do the maneuver? And what I told this young RT was, you can measure a plateau pressure on anybody at any time. You just need to understand what it means, like what the data you get back, what the visual data you get back, the visual clues, the patient assessment, and the numbers that you get back. You have to understand what those are telling you. They don't all tell you the same thing. Just like when you mentioned, doing a plateau pressure in a pressure mode of ventilation doesn't, so you can't assume that the pressure you have dialed in is what the plateau pressure is what the resulting plateau pressure is going to be. So that's a really good point.
Yeah, and I think, Troy, you would probably agree that a respiratory therapist should at least once per shift perform an inspiratory and expiratory pause.
Mhm.
Like,
If the
just
sensor allows it and you've got enough time
yeah,
to
as
do
long as the
that,
vent allows it. Some ventilators in certain modes won't allow you to,
Right.
but yeah, when you can perform these
yes.
maneuvers, it tells you a lot of information, really.
A good time to do it is right when you set it up, but you should be doing it every shift if you can.
Yeah, even when they're spontaneously breathing, if your patient allows, like if the ventilator allows an expiratory pause, you can calculate things like POC.
Yep.
These are all useful tools, just and information you can get by simply just doing a pause maneuver, right? So it's yeah, I like I said, I feel like we're taught about these inspiratory holds and what plateau pressure is, and then it just sort of, once you get into clinical practice, if the site that you're working in is not commonly performing these measurements, you just follow suit, right? Like if nobody's giving information about resistance or total PEEP or on handover, you're probably a lot less likely to start doing it yourself, and and being the one that stands out. But please stand out.
Yeah.
We want you to stand out.
Troy, when you
And
said
Right.
when you first start it up, what just for the listeners, what you mean is when you intubate somebody and they're potentially you've potentially given them a neuromuscular blocker, that's the perfect time to do some of these mechanics
Yes.
measurements, right? And so
Yes.
you should definitely do it then, and then you should understand what those changes mean throughout the course of the patient, the patient's illness and intubation.
Yeah. It's not unusual. You'll have somebody on non-invasive with not a very high inspiratory pressure pulling a lead or tidal volume, and we decide we're going to intubate them. And you intubate, all of a sudden your plateau pressures, your driving pressures are extremely high. What happened? Well,
Yeah,
you're
that's when you
conflating
realize
patient.
how much work the patient must be
They
doing
were
to be
actually
pulling in
doing.
those volumes. Yeah.
Yes.
Yeah. No, I always really appreciate when people take a lot of screenshots, because I mean, my computer is just absolutely full of screen. And I the thing is, these screenshots become timeless in terms of examples, right? Like once you like, I've been using the same screenshots for certain education purposes for like, I have some screenshots that are probably like, I want to say 15 to 18 years old. Like pictures from, I have some that are pictures on cameras before I had an iPhone. Like they're just totally like horrible
Mhm.
quality. But I'm like, I have to capture this. This is fantastic. So it's nice to see such a pattern of that. And some ventilators make it easier, right? Like some you got to bust out your phone and take a photo of the screen, always making sure that you don't see anything reflecting in the screen that could, identify a patient, of course. But and then other ventilators make it
Break
really
something
easy
where you
to.
can identify me because
Yeah.
I'm
Oh yeah. Yeah.
using
No, you
all
can
digital,
only
and you could
you can
see
usually
my
tell I'm the
reflection
one.
in the
Like,
big
yeah.
Oh,
screen.
that's
You can
Troy. I
usually,
see him.
yeah, you can usually tell if the patient's isolated because I'm wearing a bright yellow gown. You
Mhm.
Right.
can see that reflection for sure. Yeah.
Well, we
Yeah.
had
No, that's good.
the two recent screenshot cases that we've had is we had a patient on a spontaneous breathing trial with a P100 less than -1, but a POC of greater than -20. And the question was why the difference? The extubation was to non-invasive, and the patient failed. They didn't do well. But there was a lot of discussion. Why is the P100 low and the POC so seemingly high? The patient had moderate effort when you observed them, and their minute ventilation was over 10, but not, I don't believe 15, somewhere between 10 and 15. Tidal volumes were on the high side. Rate was in the 20s. Um, and I just threw out the question, look at this. The POC is quite high. They look moderate. It looks like he's using a lot of accessory muscles. And so that it spurred a really good discussion. What does the P100 reflect versus what is the POC reflecting?
Yeah,
And
when I
maybe
saw that case, when I saw you post that, Troy, like I'm actually just currently going through a revision with a publication on assessment of respiratory drive. When I saw you post that, I'm like, I need to talk about this. When I make my revisions, I got to add a little statement because I actually focus on the opposite occurring, where you can have a high P0.1, a high drive, but then your POC is low, and this just indicates that your drive is there, but your ability, like the actual effort output beyond, so the action of the diaphragm is weakened, and this can identify patients that have weakness of the diaphragm. But when you posted that, I was just like, oh man, yeah, this is, and again, I don't know the results of that, but I can at least offer up my thoughts on what again, I didn't follow your thread. I saw the original thread, but I didn't follow to see if anybody was suggesting this or not, but maybe you can clarify. But when someone has significant auto peep, for example, the P0.1 represents the pressure drop once they trigger the ventilator, which could be near the end of their
Uh-huh.
effort. So it can be at a very different point. If you just think of esophageal swings as, going down and then back up, by the time it triggers, there might not be as much of a slope, right? So your P0.1 can be low, but if you measure that whole distance, right, that whole swing, doing a POC, you basically measure that swing. The number's not exact to esophageal pressure. You have to multiply it by a conversion factor, but those two represent two different things. But one of the issues is that the ventilator measures it at the point of trigger. So if you're having trouble, if there's a delay in triggering, your P0.1 is not going to reflect the overall drive. Did you find that patient probably had some auto peep, or did they have any?
well, interestingly enough, not really. Didn't have
Hmm.
much auto peep. So I think or at least my assessment was the neural drive was fairly low, but once the action occurred, the effort was quite high.
But you said their
Um,
tidal volumes were quite large, right?
yeah, they
So
were
they may
higher
not.
than eight mils. It looked like he was using mostly accessory muscles. I wondered if there was maybe something wrong with the phrenic or something. I don't know. Um,
Yeah, I
I,
should
I'm
I should clarify when I say auto peep versus just like hyperinflation. Like if someone has like a liter of tidal volume that they pull in and then they exhale, if they don't exhale all that out and they start inspiring, and they're inspiring from a elevated, end expiratory lung volume, perhaps that they might not trigger it, but that's harder to assess essentially. Like without an esophageal balloon, you really don't know how much pressure is being generated just to reach that trigger sensitivity.
Did
But
you shoot NAVA numbers on that patient?
I would have done that
yeah.
pre-intubated. They transitioned afterwards. They weren't able to come off the non-invasive for a couple of days, and they didn't want any of that because it probably would have resulted in a tracheostomy and such.
Yeah.
But that was going to be my next suggestion, was to either put a esophageal or a NAVA catheter in.
Yeah, then you can truly assess whether there's some, again, when I say auto peep, it's just essentially their effort starts at an elevated level of lung volume that then affects their ability to trigger and therefore delays the P0.1 value from when their effort actually started. But yeah, that's a tricky one. So now so I'm looking through my manuscript yesterday, and I'm like, I should probably add somewhere in here that the reverse can happen. Well, again, particularly a very common way for that to happen would be with an inability to trigger, where by the time the P0.1 registers a value, it's it's near a different slope in the effort. But this sounds like that might not have been the actual problem.
Here. So I was quite curious, but again, screenshots, discussion, just like what we're having now. It's good. It's good, I think. And so I'm always ready to with an interesting case. We've had patients, in my opinion, two of the hardest type of patients to ventilate as a respiratory therapist are those with a BP fistula,
Mm.
persistent BP fistula, so they have a big
Yeah.
leak, and
Uh,
refractory bronchospasm for whatever the reason. Very difficult. ARDS, we've done it so much now and so often we kind of know what we're doing. I mean, we still have a lot of room to grow there, but we kind of know we need to do this, we need to do this, we need to do this. And then with BP fistula, it gets a little tricky. And
Oh
same
yeah,
with
because half the time
refractory
part of the lung needs some PEEP, but we know
triggering.
we know PEEP loves a fistula.
Yeah, triggering
Loves
auto, false
everything.
triggering.
Yeah, yeah,
Yeah,
the leak. Yeah.
yeah, I haven't
it's
had one
difficult.
of those in quite a while, knock on wood, but yeah, they certainly are tricky because you have to treat each side of the chest differently. And, you may have to, do independent lung ventilation. You might have to change the ET tube to
It's funny.
endobronchial tube or,
I remember the times where if you had somebody on 10 or 12 a PEEP, we had a needle at the bedside because we were just sure they. And back then, there often were a lot more pneumothoraces than there are now. Now we use
Mhm.
15. With a higher BMI, 20s PEEP. I rarely see
What tidal
attention.
volumes were you using before when you had the
Yeah, we
needle
were
at the
using,
bedside?
large 10
Yeah, of
mils.
course.
When
Yeah.
I started, we used 10 to 15 mils of
Yeah.
actual weight
We're
back
like,
then.
this
Yeah,
PEEP's going to cause the pneumo. It's like, no, I'm
right.
pretty sure
Yeah.
the 12 mils per kilo is going to cause the
Yeah.
pneumo.
So our fellows argue, if they have a tension pneumo, they want that experience because it doesn't happen that often. And
Right.
back 25, 30 years ago, it was a lot more frequent.
Yeah. Go ahead, Keith. Sorry.
I was just going to say, I don't want to backtrack much, but it seems like the data and the interest in the literature and the focus has shifted more recently to really paying attention to over support and under support. A lot of data about the diaphragm and too much hurting the diaphragm, not enough hurting the diaphragm. Would you say that that your practice and the way that you teach has been influenced by that in terms of POC and P01? And how often do you do that measurement?
It's initially, so we have P100 incorporated into our charting, as well as if we document a plateau, it automatically calculates the driving pressure. It's not smart enough to understand if we do auto PEEP to look
Right.
at the difference there, but it does give us a number.
I
But
mean,
we started,
the argument is the Amato paper didn't use total PEEP.
didn't
Like
use it,
we
right?
all
Mhm.
feel that that's
Correct.
the important driving pressure, but when we look at
Yep.
the associative data, much of those that they didn't have total PEEP for everybody, so they used set PEEP. So there's that.
Right. The time that I really started paying attention to what you're describing there, Keith, is when we started putting Nava catheters in. That was quite a while ago, and we found about 30% of our patients, we thought there was something wrong with the catheter when really they were just false triggering. So it really threw up a red flag. We had case after case after case, and I started documenting these cases. And at the time, we were using the serval eye ventilator, and it was so dramatic. I think back then, the serval eye, the default flow triggering was 5, and I think we went through all our ventilators and changed it to 2. I think the serval eye is one of the few ventilators where as you get closer to 0, the trigger becomes more difficult because it's not in liters per minute.
Uh-huh.
So we made the trigger more difficult by turning the default from 5 to 2, and we did that across the board. So we started paying attention to false triggering and over assistance about the time we started using Nava catheters. Now, the opposite can be true. We saw a lot of people with really high effort too. But now when I do assessments, if I see a patient without any observable or measurable air trapping or auto PEEP, I'm a lot more apt to use pressure trigger just to try to engage the diaphragm just a little bit more. If they have any kind of measurable or observable air trapping, I'll almost always use flow trigger. May not make a huge difference, But when I have Nava catheters in patients, when I do, it does seem to affect the EDI. It may be less than 5 and going from a flow trigger to a pressure trigger, then it comes back to lower normal, and it looks like they're more engaged. So there's other things you can do by decreasing the support, talking to the nurse about sedation, things like that. But we do over support more patients, and I think false triggering happens more often than we're aware of. So we're pretty acutely aware here. And doing that expiratory hold, you get two things. What's the POC? And is maybe they're not pulling at all, or maybe very
There's
little.
effort. Yeah.
And you can make some changes with sedation or your inspiratory level, or you trigger a little bit or whatever you're going to do.
I think we underestimate the use of the Navic catheter as like as a monitor. Even if you're not using NAVA mode. I had a similar story where we put a catheter in a patient who looked like they were working pretty hard to breathe, and actually the staff had removed the catheter and thrown the first one out because they thought it was broken. And then they put in a second one and they still didn't have a signal, and they're like, something, something's not right. And so we did diaphragm thickening fraction on the patient and found that although the diaphragm was moving, because when volume goes in the lung, the diaphragm moves if you're on a ventilator. That's why excursion doesn't usually give you the same information, but there was no thickening fraction. Like there was no, it basically was telling us the diaphragm was not contracting. So we're like, there's not a signal. Like this diaphragm is not depolarized. Like there's just no signal going through this diaphragm. So then it became a monitor. Like the patient didn't have a reason. Like there wasn't a surgical reason for this. It was just for some reason there was an issue with the phrenic nerve. And then it just slowly, like we started seeing EDI come over days. So it became a nice monitoring tool because up until that point, there's really no point in weaning the patient's using accessory muscle. Like we're trying to wean and they're just using more and more accessory muscles. And it's like, you can't maintain that, right? Like this is people can, but this patient we need to train to do that. It's not like, we're not just going to pull them off the ventilator and be like, good luck without your diaphragm. Good luck shifting that diaphragm without any help from the ventilator. So it really told us a lot of information, and it sort of made us stand back and be like, okay, we need to be a bit more patient with this guy. Like, I like what you said about how, we try to get patients breathing spontaneously as quick as possible, but within limits. Like you obviously can't have a patient working so hard that looks like you're doing everything on your own, let's take you off the ventilator. It's like you can't sustain that if the work is super high. And so it definitely gave us a lot more information having that catheter. It's just part of the problem with a lot of this technology, what's unfortunate is that it is proprietary, right? So you can't use an EDI catheter if you don't have a specific ventilator. So this is always the challenge. It's what I like about transpulmonary pressure is that at least most ventilators are now adding the port. So like you just need a catheter of your choice, and mostly you can use your own catheter. You can pick
to the
you can use an
monitors.
ICU monitor if you want. Yeah, for sure. But it's nice that at least the ventilators integrate the esophageal pressure measurements so that, and again, it's not proprietary, it's just the technology is there. And the ventilators can obviously measure pressure. That's what they do best. So it makes sense that they should all have it.
Have you utilized the automated positioning tool on the U yet?
I've seen it, but I haven't used it clinically. So when I was at
it's nice.
It's nice. It's really nice. Oh yeah, so I've seen it step by step, but I haven't had the opportunity to use it clinically. But like, what a good idea, right? Like, just help. I mean, I wasn't surprised because they have the same thing with the Navic catheter, right? It kind of guides you through placing the Navic catheter. So when they implemented transpulmonary pressure and esophageal pressure, it made sense that they did that. But I was really happy that they did because it really makes just gives you this visual idea of like what it is you're measuring and what it is you're testing for positioning, et cetera. So yeah, huge benefit for that software. Keith?
EIT.
Yeah.
Tell us about your EIT experience. When do you use it?
It was an interesting concept that was initially brought up. So I think both of you know Ariel Canero. He was working here, brought it up, and had made some initial contacts, and then he moved on to the Cleveland Clinic, and I kind of got left with me. And we ended up getting a trial here, and we found it useful enough where we still have it and we use it. We use it on all our VV ECMO patients, almost all the VV ECMO patients. We use it before they put them on to try to see if there's anything we can do to optimize the ventilator. And then we leave it on when we prone. We usually leave it on when we cannulate them. And if we have to take it off for a while, sometimes we'll replace it. But I think, with a, as with a lot of things, on neutral, I have to be neutral because there's not a study that shows a mortality benefit or outcomes or things like that. But I'm neutral positive with
Yeah.
EIT.
Mhm.
I think I love the fact that it's non-invasive. And yes, there is a learning curve to know how to get the belts placed properly and get it hooked up. The biggest problem we've had with EIT is we measure these patients, and then if you get it ready and you've mismeasured or the measurement isn't just quite right, you may have to change to a different size belt. And that's a little frustrating. We're getting
Yeah, and
better
depending
with
on the
that.
manufacturer, that might mean you're throwing out the belt because it's a sticker, right? Versus
Yeah,
versus like the Palma Vista with Dragger, I know it's not available in the US, but they have a rubber belt that if it's the wrong size, you just wipe it down and hang it back
right.
up in your department, right? So there's benefits to that as well.
We
Um,
haven't gotten any pushback really from the nurses or even the
mhm.
physicians that don't love it. They'll say, well, that physician's here today. Why don't we just put on EIT and have you guys look at it? So we've gotten pretty good about putting it on. We're in the middle of a OR study with patients with high BMI that get pneumoperitoneums, and we're looking at some of the classic PEEP settings that you might use by
Mhm.
anesthesia versus what you might use with EIT.
I think what I
Um,
love about EIT is that it's the first time that we've visually been able to understand this idea that PEEP is always a compromise.
yes.
Right there,
Yeah.
when we talk about optimal PEEP, there isn't an optimal PEEP. I know I've given talks with the title
Yes.
saying optimal PEEP
Mhm.
guided by blah blah blah. It's like, but once you start using EIT, you realize it is always a compromise. Where you have the lowest collapse, you're going to have some significant overdistension, right? So, and it's the first tool that allows you to say, hey, listen, I can see overdistension and collapse. Perhaps I want to balance this out. And
It's
so visually,
worse.
you have this idea. And so, in terms of what's worse, there's some interesting animal data that would suggest that the collapse is worse.
I've
But
seen
again,
that.
based on animal data, I would argue I would probably depend on how much overdistension is occurring at that lower collapse. Right? If it's like 10%, that's one thing. But if depending on the patient, again in an animal model that's highly recruitable. Collapse is bad. So how that would translate into humans with a large degree of varying recruitment potential, I don't know, but as the animal data is suggesting, perhaps collapse is worse. And this highlights the point that and with EIT, you'll learn very quickly that sometimes the best or highest compliance actually equals a significant amount of collapse. And then there's tidal recruitment, so the compliance is good, but there's some tidal collapse going on, and re-recruitment, and so compliance as a way to set PEEP, it's not horrible, but it may not be telling us the full picture, and this is where EIT is telling us a lot of stuff. So I have a question. Maybe, sorry, go ahead, Troy.
EIT show you compliance that's relatively minuscule change over a wide
Stable, yeah,
variety. Yeah. So
yeah,
you
because the
might choose.
overdistension and collapse is trading
Yeah,
off,
Yeah.
while
the
your
yeah,
compliance is just
compromise.
yeah, and this is one of the things you'll see. Compliance is kind of like, okay, well, if I were doing optimal compliance, where would I set it? And some people say, well, when it decreases again, I would set it 2 above. Or there's like, well, as soon as it gets optimal, let's just start
Yeah.
there. Like there's no full agreement, but the reason why it maintains stable for a number of peak drops is because as collapse is getting worse, overdistension is getting better, and you're just getting this trade-off. But being able to visually see that trade-off is just it's such a new concept. So maybe a final question. We can wrap up our interview with you, Troy. If you had to go work on a some remote place, you can say it's a beautiful tropical island. I don't care, just some remote
Let's
place,
let's say that.
and it's let's say it's a 10-bed ICU, and you regularly have ARDS patients in this ICU, so they're complex, and you could only bring one tool, but you had all the equipment to go with that tool, and your choices are a navicatheter, an esophageal balloon catheter, or EIT. What would you, if you had to choose one, and then I'll ask you if you could had a second backup, what would it be? And again, this is not an endorsement of any company. This is just based on because you have years of experience, and kudos to you for practicing this long and having an interest in the new technology and like really embracing it, because I feel like the longer anyone is in a career, the less likely they are to like grab onto new stuff. They're just gonna be like, I'm good.
Old dog, new tricks. Remember?
Exactly. It's the
Yeah.
whole old dog, new tricks thing, right? All right. So back to the question. If you could
So
only choose one, what would you choose
first off,
based on your experience?
I work in a medical ICU with pulmonary critical care, nephro critical care, ID critical care. You have to stay a step ahead of them, or they're going to get you. They're always, well, what about this? What about this? I don't want to be broad, so that's why I've tried to stay up on. I want to know what they're talking about when they come to
For
me.
sure. Yeah.
If I'm on an island, and all the tools that I've had, and I think all three of what you mentioned, I could utilize with an ARDS patient.
Absolutely.
think-
That's why this is a
That's
tricky
the point.
question.
Yeah.
I'm asking
Even-
you because I've been asked this question. I'm asking you because I've been asked this question.
EIT, then transpulmonary.
Yeah.
As long as I could prone them. Thank goodness we were
absolutely.
proning. We were
Yeah.
proning way routinely way before COVID. We had
Yeah.
5 patients.
You
proned
actually
in
paid
that-
attention to Proseva? That's good.
Yeah, we were
Because
proning
many
way
people
before.
did not. Yeah.
It turns
I will
out you
say-
can prone anybody, right? You don't.
Yes.
When
Yeah.
I first started out, we had to use the striker frame,
Oh,
there was
the whole bed that flips
Yeah,
over.
the
Yeah,
whole
we've never
bed,
had
so-
that in Canada.
and if you were using it, we only had one, and if you were using it, then that person's the only one getting prone. But now we know that regular bed is just
Yeah, you can
the way
prone
to
somebody
go.
anyway.
The way
Yeah.
to go.
So now let me throw. I'm gonna. Now on that island, you are exclusively taking care of patients with morbid obesity. So this adds an additional challenge to caring for these patients. If that was your patient population, would you change your selection at all?
Yeah, the EIT belt's not going to fit on a lot of those patients.
Okay,
so,
now let's say you had equipment. Let's say you had a belt that would fit every patient. Would it change your?
I really like transpulmonary pressure for the high BMI, to be quite
Yep.
honest with you.
I just-
But
That's
I'm like,
what I would choose.
I wasn't gonna even smile or hint or anything,
No.
but yeah, to be perfectly honest, when you think about protocols with EIT, right? What's your
Mhm.
protocol for selecting a PEEP or for doing the PEEP titration? What's your protocol? Like, what PEEP do you start at?
So
Because it's a decremental PEEP essentially,
we usually start with a compliance-based peak. That's where they're at.
right?
So then we'll go 4 to 6 over where they're at and try to go as low as we can and try to get as many stops as we can.
Right. So what I've found with patients with that challenge of morbid obesity is that you would need to change your EIT protocol to start at probably a much higher PEEP level in order to capture the PEEP that is right for that patient at that time. Whereas with esophageal pressure, when I used to want to demonstrate to people the magic of transpulmonary pressure, you pick a patient with morbid obesity and you say, watch this. You got them, they're already on a PEEP of like 14, perhaps 12 or 14. We used to get patients sent to us all the time on a PEEP of 12. And like 80% FiO2. And then you put that catheter in and you see that the pleural pressure is like 24 and you turn the PEEP up to 24 and now they're on 30% FiO2 and their compliance just doubled. And like it's all of a sudden, but then the next question is like, how do you wean those people? It's like, well, you wean them slowly, correct their medical condition, but now the lungs are we're not contributing to further issues by ventilating a lung inappropriately, right? So I agree with your I agree with your answers, and I actually would answer the same. I would probably choose EIT for the bulk of patients, but for those who that work in a hospital that have a lot of patients with morbid obesity, I would say put in the work for understanding and getting used to using esophageal pressure. I feel like it really opens your mind and you realize how scared you were of PEEP in a population that really needs PEEP.
If you have a Nava catheter in with an active patient with a high BMI, and you're not using the right PEEP, your EDI is going to be quite
That's
high.
huge.
As you increase and get closer to where you should be, you can watch the EDI. So it can be used in that way.
Yep. All right.
Perfect. All right, gentlemen, I think we'll wrap it up. Appreciate you both. Troy, thanks for joining us today. And if you're listening out there, again, this podcast is part of Inspire Respiratory Critical Care. You can go to www.inspire-rt.com and you can find links to all of these podcasts and to our panel discussions and our methods to even there's a link on there that you can recommend future topics. So do that, and thanks for joining.